Thank you, thank you. So once again, I just want to say community health workers are essential frontline professionals who work at the intersection of public health.
Lisa Bledsoe is now exiting.
Okay. Healthcare and the communities we live and work in. We are known as CHWs, and we share similar life experiences, challenges, and the hopes of the people we serve. The community health worker scope of practices focuses on working with patients outside of the medical office, yet when we are part of the whole person, patient-centered care team, CHWs allow other practitioners to work at the top of their licenses. One of the foundations of community health workers' scope of practice is health education. CHWs discuss the importance of early screenings, staying active, and eating healthy. When someone is newly diagnosed with a chronic condition like hypertension, diabetes, or heart disease, CHWs help them understand their condition and how to manage it. Community health workers can also support folks diagnosed with acute illnesses like cancer, health failure, and stroke. We show people how to take their blood pressure and blood sugar, understand treatment plans, and know how to seek help. Community health workers also do home visits as well to make sure patients have skills and resources to carry out instructions and have the support they need to stay healthy and out of the emergency room. Additionally, CHWs help people navigate healthcare and human services systems that are overwhelming and confusing. Have you ever struggled with finding a doctor, being referred to a specialist, or filling out health forms? Imagine living in rural Barnwell County where the closest specialist is 35 to 100 miles away, and you yourself are underinsured. Working men ages 19 to 64 are the most likely to be uninsured or underinsured. As the cost of coverage increases, early interventions and care navigation will become even more important. CHWs connect people to rural, community, and free clinics or other screenings and treatment opportunities. Community health workers themselves also help bridge technology gaps. Many people in rural areas do not have access to smart devices or high-speed internet. Even folks who do have access to these abilities might not understand how to use Zoom, download apps, or upload their personal health data. It could be overwhelming with the challenge of this being about their health. Sometimes community health workers accompany patients to specialist appointments to ensure they fully understand their care and can actively partner with their care teams. Because we conduct home visits, community health workers can bring valuable information back to those care teams. There's more. Community health workers are experts in outreach, meeting people exactly where they are. This may be at community events, churches, basketball courts, barbershops, or workplace clinics. We work through community-based and faith-based organizations that already have strong roots and relationships. Hospitals and clinics often partner with these organizations because CHWs reach people who are hesitant to walk through a clinic door on their own. To be clear, CHWs are not caregivers. What we do is we teach people the skills to take care of themselves, how to partner with their own team, and connect back to their resources. The CHW workforce completes core competency certification through the South Carolina Community Health Worker Credentialing Council. This ensures high standards, continuous professional development, and opportunities for advancement through tiered certifications. Currently in the state of South Carolina, there are over 800 certified community health workers through community-based organizations, health departments, and rural and community provider practices. Because community health workers touch families, not only patients, we impact nearly 500,000 South Carolina residents each year. In 2014, a return on investment study that the South Carolina General Assembly paid for found that for every $1 invested in a community health worker, there's an average return of $4.96 in healthcare savings. That return comes from early interventions, fewer missed appointments, and improved health outcomes, and reduce unnecessary emergency room visits. And then finally, I would like to say that community health workers are a trusted health professional, workforce community members who meet people exactly where they are. They help them navigate care and support them and living healthier lives, fuller lives. And to end, CHWs are a great healthcare investment. And thank you for your time.
So I appreciate you being here and your service as a community health worker. You said there's over 800 community health workers who are certified in the state.
That's correct.
Are they concentrated in certain areas? Are they equitably distributed across the state? Can you comment on that?
So they service in a broad area case in which, speakers behind me will also talk more about the specialty areas that they will cover.
Okay, so like you live in Columbia,
Yes.
and you work a certain area in South Carolina?
So I'm with the South Carolina Community Health Workers Association. So my range is really the whole South Carolina. I just live in Columbia, Lexington area.
So have you been engaged in any kind of prostate cancer awareness initiatives? You yourself?
Yes, and my team behind me is going to speak more about what we're
Okay.
doing.
Okay, all right, great, thank you.
Mr. Chairman, can I interrupt the process just 1 second? Unfortunately, Ms. Bledsoe dropped off and was unable to communicate with us. She did, however, send her presentation.
Can you hear me? I'm able to hear now.
We can hear you. Can you hear us? You must be
I
able to.
can. Actually, we have been successful. Thank you.
Oh, great. Well, then, before we continue with the community health workers, we'll go ahead and proceed with your presentation with Self Regional. Is that okay?
That is wonderful.
All right.
Thank you very much.
Well, we sure appreciate you being here. It's my understanding that there is is that something we can see on our?
Yes, sir.
tablet?
The last document on the left margin of your console, titled Self-Regional Prostate Cancer Information, is the presentation that Lisa will make to us on behalf of Dr. Hansen, who was unable to be here today.
Okay. All right. So, Ms. Bledsoe, are you a physician?
I am not.
Okay. And we really appreciate your being here and understand that what's your role with Self Regional Healthcare?
I am a service line director for urology, orthopedics, and podiatry.
We sure appreciate your work in that area. If you would please proceed with your presentation.
Sure. I have just some statistics that I'm going to share with you, and I believe that you guys have been provided a handout with these facts that I'm going to present today, and we just really have
grown in our prostate cancer cases with self-regional healthcare since 2021. The treatment options that we have available, and that'll depend on what stage the patient is in when they are a diagnosis is confirmed. We may what they call wait and watch. If someone's PSA is elevated, depending on their risk factors, their age, and how much it is increasing, it may be a wait and watch thing. It may end up and we do a prostate biopsy to confirm if it is prostate cancer. And if so, the surgical options, we do have a Da Vinci robot here itself. We actually have 2 of them, and we can perform robotic prostatectomies. In addition to that, our oncology, medical and radiation oncology offer services for both radiation therapy, chemotherapy, hormone and immunotherapy, and then targeted drug therapy. We have in the past, and I could not confirm before this meeting, but we do affiliate with MUSC for clinical trials. I am not sure that prostate cancer is one of the areas of which we participate in clinical trials with MUSC. If you will follow along with the incident rates by county, South Carolina is ranked number 2, or McCormick is ranked number 2 in South Carolina as one of the highest areas of incident rates. And so we probably need to focus more on that area with education, screenings. A snapshot of the prostate cancer in South Carolina, according to the ACS, is we roughly had in 2023 5,770 cases. Deaths also in 2023 estimated at 640. South Carolina, top cancers in South Carolina, breast was number 1, where prostate cancer was number 2. And we have a radically diverse population where African American comprise about 27% of the state population, 14% of these live in rural counties, and 75% of the counties in the state include areas that are designated as rural. It is more prominent in African American men and is the second leading cause of death among men in South Carolina, as I mentioned earlier. The incident rate is 80% higher in African American men compared to prostate cancer rates of white men in the state. And right now in urology, we are providing outreach in 4 of our 7 county regions. We have weekly clinics in Lawrence, Edgefield, Abbeville, and in November we start in Newberry. And as far as screenings, prior to COVID, we were offering screenings for prostate cancer. There was a lot of controversy around the screening guidelines, so that kind of ceased in COVID and during COVID, and we really haven't ramped back up. But we discussed shared decisions regarding our screenings and how we can review and order those results. Back in September of last year, Dr. Hansen spoke to the Edgefield community about prostate cancer. And this, along with other educational efforts, have made a positive impact. We are seeing more primary care providers screen more patients, and we're seeing more patients appropriately referred to urology for further evaluation. The risk factors, again, mentioning that African American men are at a higher prostate cancer death rate. There are difference of opinions in screening guidelines based on where you look. Mostly men around the ages of 55 to 69 should consider that, and that should be part of their decision-making criteria with their primary care physician. And again, rural counties like McCormick have a higher incident rate, maybe due to limited screening and limited education in those areas. We expand our community outreach. These are our recommendations, is to expand the community outreach and monitor Pluvicto implementation, enhance our data collection, and partner with local organizations such as churches, barbershops, civic groups. I think to the young gentleman who just spoke before me about being a community health worker, I do believe that they can definitely help educate and promote some of these awareness and screenings through the churches and groups that they participate with. And then the last piece were just 3 different areas that talk about their ages for screening and risk factors, if there's a family history, if there's not a family history, kind of what the norm is. And, you know, we just take all of those different guidelines into consideration with prostate cancer. What questions?
Yes, I have some questions. I'm sure others may as well. So your presentation mentioned that Dr. Hansen spoke with Edgefield community residents in September 2024, and that led to a positive impact in that community. What was that can you tell us more about that outreach? Was it was it at a church, or was it at a self-regional facility? Tell us more about that.
It was at a self-regional facility, and we did promote that throughout the community. I would have to find out for sure exactly how we promoted that event. To be honest, it was not, the attendance that we had anticipated was a lot less. It was a lot less than we anticipated, so we were a little disappointed with that, to say, but I think with concerted efforts moving forward, we can beef up that awareness and hopefully have a larger audience in the future. We did have attendance from our own primary care doctors in that area, and a lot of them are self-regional primary care doctors. And I do believe that educating them on, you know, screenings and what to do next in different stages and when to refer to a urologist really helped that put things into motion for next steps with prostate cancer.
You mentioned too that that Self Regional has a urology outreach clinic in the geographic area where the self-regional footprint is, that includes Lawrence, Edgefield, Abbeville, and Newberry. Newberry is scheduled to begin next month. Can you tell us, is that a brick and mortar clinic, or is it, can you tell us more about what that is?
Sure, absolutely. So the current clinics that we provide now, Lawrence, Edgefield, and Abbeville, those are self-regional PCP clinics, or in Abbeville, we have what's called a specialty clinic. So it hosts urology, general surgery, different specialty practices in that location. Newberry is a primary care clinic owned by Self-Regional Healthcare, and we're going to embed ourselves in that outreach, in that primary care clinic to provide those specialty services.
How successful do you think your urology outreach clinics are as to promoting prostate cancer awareness?
I think the more we partner with the primary care, now you asked me how successful, and I don't know how successful. I can make a recommendation that the more we are there presently, the more we can communicate and educate the PCPs on the importance of screening and educate them that we are a partner with them in this with this diagnosis, and how we can help manage those patients for them. A lot of times patients are referred to urology for prostate cancer, and they really just have an elevated PSA. So they may not turn out to have prostate cancer. However, we take those patients through the pathway to determine, are we dealing with prostate cancer, or are we dealing with other medical diagnoses that can be managed otherwise. Did that help? Did that answer your question?
That's helpful. I want to ask you, I know others have questions. I want to ask you about McCormick. You mentioned McCormick based on the 2015 through 2019 5-year period, number 2 in the state in prostate cancer occurrence in its male population as far as the 46 counties. Do y'all have any analysis of the men who were diagnosed with prostate cancer in that 5-year period in McCormick in terms of their age, race, any other socioeconomic characteristics?
I do not at this time. However, I can ask if we do have a database where someone helped pull a lot of this information for me, so we could potentially dig a little deeper into that McCormick data. And you were asking for age, race, ethnicity?
Yeah, I think I would be interested, and I know others on the committee would be interested in are these primarily older men? Are there younger men in particular that there's a higher rate in the McCormick area and than you would normally see in other parts of South Carolina? I mean, I'm just curious. McCormick is, if it's in one of the 2 or 3 smallest counties in the state, and yet for it to have the second highest rate of prostate cancer in a 5-year period prior to COVID jumps out at me. I'd like to know more about the data on that, if there's some way we can zero in on that a little bit closer.
Sure, I will try to get more details.
Others that have questions? Doctor?
Hi, just a quick question, and maybe you have this, maybe you don't. Nationwide, about up to 75% on average of prostate biopsies find no clinical significant findings of cancer. Do you know what your stats are for the biopsies?
Say that again. Ask that question again, Doc, because it kind of stunned me. I'm
Sure.
sorry.
Nationwide, about 75%, up to 75% on average of prostate biopsies that are done, they find no clinically significant. Now, what you mean by clinically significant is the aggressive cancers and no cancer. So no clinically significant cancer. So I'm just curious, is that something you guys track regularly, or could you pull that out of your database? I'm just curious.
I do not know that specifically, but I'm thinking we could pull that out of our database.
Thank you.
Representative
I
Alexander.
have two questions. Thank you, Mr. Chairman. Two questions. One directed to you, Doctor. What is considered a clinical significant observation? Someone.
I have it all outlined in our interim report. This old brain doesn't keep all of those stats in there, but it's usually like a Gleason score of, I don't remember. I don't know if we have any urology. Here. Like a. 7 or 8 or higher. Yeah. So it's the stuff you worry about. That's the easiest way of saying it. And
The medical field worries about, because we wouldn't know.
the urologist would
yeah,
worry
because
about
we
it.
wouldn't know. I wouldn't know if it's, if it was clinical significant. I just know that I have something that's going on, and I was just curious about that and how we manage that going forward. What may be clinical insignificant to the medical field is very highly significant to me if I'm diagnosed with whether it's watch or wait and watch, or whatever the term might be. And I think we probably need to move beyond that in some degree in terms of what's clinical significance and what personal significance might be. And I don't know how you coincide all that in one setting. But my question is, particularly in those 5 counties that you all have diagnosed, I'm wondering what the statistics look like across the board from a statewide perspective. I'm from Florence, the PD area, and the PD area is considered one of the most marginal, insignificant service of medical attention there is. And I'm just wondering how all of that works when it comes to other parts of the state. I understand up in that part, but what happens down in the PD area where the African American count is much higher than McCormick or Lawrence, population-wise? Thank you. How do we coordinate that, or how do we reconcile that in terms of looking at that data? Yes, McCormick may be number 1, but other areas is just as insignificant. Insignificant. Maybe as significant in other areas. And I'm not saying that for you to address, but I'm just saying that that's something that we as a committee need to look at and not just zoom in on just one area, but across the board.
Dr.
I
Hebert
agree with you, and we were just reporting on the 7 county regions that self-regional serves.
Dr. Hebert's an epidemiologist. He can give us I think we're stuck on the word significance and maybe explaining the difference of statistical significance.
Yeah, part of our job is to determine what cancers will be more aggressive. That's what we mean by significant. So it's up to you to worry or not. That's your business. But we want to be able to guide you as to something that is worth worrying about versus not. And that's the whole principle of active surveillance is come about because of that, because we were treating disease much too aggressively before. And that's one of the motivations for the U.S. Preventive Task Force recommendations to reduce the amount of screening. The other thing that I'll say relative to looking more deeply in the data, there are a couple of issues here. One of them is the rates are very dependent on the amount of screening that happens. So my question was going to be related to screening. So the more screening you do, the more indolent cancer, that is cancers that aren't worth worrying much about, you're going to see, and it will drive the rate up. So that's it's a little counterintuitive. You think, oh, you're doing a really good job of screening, therefore you should see fewer cancers, and the opposite is true. The more you screen, the more you're going to see. And then the other part of your question, I think this is where you were going with this, is you could stratify the data according to different things. And one of those different things would be race. So that would be hugely important because you know that black men and white men have very different rates of prostate cancer, incidence as well as mortality. So I think I covered all the points that Ron wanted me to talk about and that you alluded to.
Yeah, and I appreciate that.
Dr. Ford.
I'm sorry. Go ahead. I'm sorry, Doc.
Thank you. This is a great discussion. So one of the things that I was wondering when looking at the data is similar. I have a similar question. So we don't know what the stage of diagnosis is of these cases, and then what's the I know this is 2015 to 2019, but it would be helpful to know the stage and the grade to know like are these early stage, are they late stage? Because I agree with the whole discussion about screening. If you look at cancer incidence rates, the upstate has very high rates of cancer incidence or new cases of cancer, the rate of new cancer cases per 100,000 people. That rate is very high in the Greenville area. But when you look at the cancer mortality or death rates, they're much lower in the Greenville-Spartanburg area, and they're much higher in the I-95 corridor of economic disadvantage because of later stage at diagnosis, lack of access to treatment, and so, and places like Florence have very high rates of cancer death, but maybe not the highest rate of new cancer cases. So in a table like this for SELF, it would be helpful to see, in this 7-county region, what was the mortality rate in this time period, or because that tells you, if you look at incidence and mortality together, that tells you a fuller story than if you just look at incidence. Because if you just looked at incidence, you would be alarmed about the Greenville area. But they're doing great because they're a wealthy area. They have access to early detection. Cancers are diagnosed at an earlier stage. And people are living and they're going back to work. They're being diagnosed, being treated, going back to work. When you look in the I-95 corridor, you see a lot of late-stage diagnosis. People are diagnosed, they may not be able to go back to work. Well, number one, they may die because of the late-stage diagnosis. And two, because of the late-stage diagnosis, the treatments are more aggressive, so they may not physically be able to return to work.
May I? And I agree with you. And I guess that's my whole point of this question, is that the Greenville-Spartanburg area, maybe they have access to, but not the I-95 corridor. So when they get access, it's almost at the end of life. And my concern is, how do we manage that? When I was diagnosed, they said, watch and wait. I'm like, what? Think about that. You got it, but we want to watch and wait. Psychologically, that's significant to me, but clinically, it's not significant. I'm not saying that. You see what I'm saying? That's when you say, well, that's the way I worry. And I understand that. I understand from a clinical perspective, but how do we reconcile that? And that is the key. How do we manage this going forward, knowing that on one end, it's all right, but on another end, this stuff is killing me. One of my doctor friends said, Terry, if you're going to have cancer, that's the one you want. I said, I don't want this. And he was my friend. I'm saying, I don't want this. So that's what we have to deal with. And how we manage that, I guess, is going to be the key, Mr. Chairman, moving forward. How we put all this together. What's happening in Greenville, and what's happening in PD, where infant mortality rate is extremely high in third world country numbers. Thank you.
So, Terry, how I'd respond to that is we just need to do a better job on the education and engagement part of this. And that's where that report is focused. Because really, it's up to you to worry or not. I mean, that's, I may not be worried under the same circumstances, but that's a personal decision that people make. And I think that the guidelines take that into account. What we need to do is a lot better job of engaging people and educating. And not just educating, because if you just educate without engagement, it won't work. And I know Ron and I have talked a lot about this, and I know Marvella and I have talked about it as well. So, we're in agreement in that, on that issue.
How do you do that, right?
Yeah, but we have a proposal in the works to figure that out. And what better place to do this than South Carolina?
So one of the things, going back to Ms. Bledsoe, one of the things that this chart on page 2 of your handout that you provided to us, the McCormick being number 2 in the state, recognizing it as small as it is, but then also the 3 adjoining counties, Greenwood, Abbeville, and Edgefield, all are 35, 37, 38 in rank. So they're similarly situated in terms of the incidence of prostate cancer in South Carolina in that 5-year period. And then McCormick, just across the county line, is number 2. And so that, I mean, we just need to know more about those numbers. I think it may help us in zeroing down on the rural, some of these rural healthcare challenges that we're trying to help provide some guidance and recommendations to put forward for the state to implement. Terry?
Yes, thank you. Thank you. Could you give us some data on the racial breakdown of those numbers that you found in those 5 counties, 6 counties?
So I heard several things, and I just want to clarify. Do you want stage of diagnosis and mortality rate? Or do you want early versus late and mortality rate?
All that.
Because, okay. I think we'll have to give an average,
Right.
stage. Because, everybody's gonna be at a different stage. Not everybody's gonna be in stage 1 or stage 2, but we can say which one's more prevalent. We can give an early versus late breakdown, and then we can give you a mortality rate.
And race in that regards too.
I have age, race, and ethnicity, and we can try to look at that as well.
Thank you.
Dr. Ford?
Absolutely.
Yes, could you give the percentage of people in each stage for each county? Like what percentage of the new cases are in stage 1, 2, 3, or 4? That, I think that would be helpful. And then it's a lot of data, but to look at it by race is a great question. Are the stages different by racial group? So are the black men at the higher stages and the white men at the lower stages, or is it spread across the racial groups?
And
I think
because it's,
that would-
sorry.
yeah. And the same for the mortality data, I think would be helpful. Thank you.
Yeah, I agree with Dr. Ford. Because it's prostate cancer, I would be more interested in grade than stage. For prostate cancer, unlike most cancers, grade is a better predictor of outcome than is stage. So having grade of disease, and there's grade grouping, but you can also just report the Gleason grade. And again, as Dr. Ford said, do it by percentages within each grade. And you could categorize it as 8 or above, 7 or 6 or below 6.
Well, and we can do stage and grade.
You could do both.
That would be
Absolutely.
really
That would be
helpful.
better if you could do it.
Representative Alexander.
Doc, could you explain the grade piece? I'm not sure.
Yeah, so the grade refers to the histopathology. So when you have a sample, either from a biopsy or you do a cross-section of a prostate gland, you're looking at what it looks like under the microscope. And some of these cancers are really aggressive. So they lose their glandular characteristics and they become really chaotic. So when you see complete chaos, it's a Gleason 10. And if it's really well organized and the structures are there, it'll be like a Gleason 6 or so. So the more disorganized it is, the more malignant potential it has. So the really disorganized cancers tend to be really aggressive. And you'll get that information from from the biopsy, you don't need to know where else it's spread, which is part of staging. So staging refers to basically how big the lesion is and where it's gone. Is it spread? They're both important, but for prostate cancer, grade tends to be a better predictor of outcome.
Ms. Bledsoe, are you
Yes,
still?
and yes, I am, and unfortunately, I'm gonna have to drop. Are there any other questions, or if there are, can someone just send me an email? I'm gonna work on gathering this data.
Yes, we can follow up with you. Mr. Hogan can follow up with you if we have any more questions. We really
Perfect.
appreciate your participating and putting together this snapshot for us.
Absolutely. Thank you. Have a
Thank
nice
you.
afternoon.
You too. Thank you. All right, so we're back to the Community Health Workers Association. I know Mr. Page presented, and now I understand we have some others. Please come forward. Tell us who you are.
Good afternoon. My name is Vernon Anderson. I reside in District 17. That was a lot of good information. I was just taking it in. Thank you all for allowing us to be here today. My topic's work is focus on men reaching men, why it works and why it matters. And we've already established that men in South Carolina are more likely to be diagnosed with prostate cancer than men in other states. And they're also likely to die from colorectal cancer. In a South Carolina study, men asked other men, why do they avoid care? Their answers were fear, cost, social expectations. Many said that they didn't want to appear weak or simply don't know where to go for affordable care. One man said, we don't want people to think that we're weak, speaking of men, so we keep it to ourselves and suffer in silence. Others said they would go if their friends went first. If our friend goes and tells me it helped, I'll go too. Their message was clear. Men respond to trust, relatability, and real conversation with peers who understand their lives. This affirms that health outreach works best when it comes from someone you know, someone who knows your story. South Carolina research shows that male-led community-based outreach increases screening rates, improves follow-up, and helps men overcome fear and misinformation. Yep, men do get scared sometimes. The same men who once avoided doctors said they would welcome help from another man who's been there. Why does this matter? It's already established with South Carolina's prostate cancer rates among the highest in the nation, and colorectal cancer, the second leading cause of cancer death among South Carolina men. Acting early before symptoms appear saves lives and reduces costs. Every early screening prevents emergency surgeries, hospital stays, and more importantly, loss for families. Men reaching men is about action, not just awareness. Awareness is good, but we got to put feet to it. South Carolina men helping South Carolina men live longer and healthier lives. With the right investment, we can turn what men told us they need, trust, access, and support, into a statewide model of prevention, early detection, and lifelong health. Thank you.
Mr. Anderson, thank you so much for those comments. So, if I may, what is your role with the Community Health Workers Association?
I'm actually private community health worker. We support the CHWs, support Ms. Terry. If she tells us, me and Mr. Ray through D-Ray Group Consulting, if she says we need help down in Bamberg to check blood pressures or just to offer support, we're there. If it's something going on in the men's fair in Sumter and the CHWs need support, we're there. If something's going on in Hemingway or Walk for Cancer, we're there. We try to we try to let love go across the state through support and action. So we try to be many things to many men or to those that need assistance, sir.
Where do you think would be if we tried to improve the general awareness campaign in, say, the African American community about prostate cancer and the need to be screened, what do you think are some things that we should consider including in our report as recommendations?
I would consider where fathers go, where fathers are. And I was telling Mr. Ray, we also used to work with the men at Healthy Start, being a support system for them for about 3 years, the contract with them. And I was telling Mr. Ray, my business partner, it shocked me that I just went to support my cousin, one of my younger cousins who had lost his father, for his basketball game. And it shocked me how many men I saw on a Tuesday night at a basketball game supporting their children. Meaning, if you can find where the children are, you can also find where you can find men. And it's just a matter of coordinating and approaching them with respect and earning their trust. Because I don't know about you, as a man, I can only speak for myself, but some of them that I've been associated with, we don't put trust. Once our trust is violated, whether it's through science, whether it's through day-to-day interaction, we kind of get standoffish. We kind of reserve ourselves to protect ourselves, and we avoid. So there's things that even though we may have health situations, when we don't trust, I think we say we'll suffer in silence.
Dr. Hebert.
So how would you imagine approaching the men at, say, a basketball game? What would that look like?
I approach them just like if I saw them on the street. Hey, how's it doing? What you here supporting the kid? Which one of those is your children?
So kind of a one-on-one, not
One-on-one.
necessarily one to a group.
You have to read the room. And if I'm not familiar with someone, I may tell them about something that's available that could be of help, but I never put it on them as if you need to do this or you need to do that, because people have to come to their own conclusion with their own decisions. But first of all, it's earning trust, credibility about that approach. And once we establish that, then the information can come. The good information that you all have about, hey, I need to get checked out. You can tell me I need to get checked out, but there are things that men talked about: fear, the cost. What if I find out that I had a positive test? We may be thinking about, in certain situations, if it's a situation as a man taking care of his family, we think about we'll die first before our family goes without.
May I?
Representative Alexander.
Thank you very much. Let me address a few things, too. There is no monolithic way to deal with African American men. There is no one shot gets it all. We have different capacities, just like everybody else. What might work over here may not work over here. We've started at Hope Health, we call Grits and Gent every first Saturday, where we meet, we talk, we chit-chat, we hear what you're dealing with, whether it's physical, mental, spiritual, or psychologically, and then we just have that conversation where you feel comfortable. Then we might go to the barber shops. Then one day we might go to the church. Then one day we might go to the game. One day we might go to the park. So there is no one monolithic ideology of how we deal with things. And that piece at Hope Health has grown tremendously. For about 3 of us, we the 3 staff, you know, in June to now, this past October, we had about 30. And the conversation was diverse. But they was in the city, some couldn't walk, some couldn't talk. They went and we started discussing health. It didn't start out like that.
They start out.
But it ended. So I don't want us to try and pigeonhole us. Because some questions I had to deal with that prompt other discussions. Not necessarily here. We're doing something at our church this coming Saturday. Not at Hope Health, but at church. So we have to just go from place to place to place
That's it.
to place and try a litany of things. There is no one monolithic ideology of who I am.
Yep. You agree? I agree.
Dr. Bennett.
Yeah, and good afternoon. I'm really glad the CHW Association is here because I think from what I've seen in the work we've done, CHWs can do that. They're trained to be drawn from the community, to understand the community. They look like the community. They know where to go. They know how to communicate. They know how to, so it's a framework that can be applied in a variety of situations, right? And I think going back to the conversation we had with McLeod and Ms. Bledsoe of how do you get men to get into the room earlier to get screened so you can watch and wait and it's not a later grade and a more severe case. And I feel like CHWs are a wonderful tool to possibly do that. They have to be in the community, know where people are, connect them to that clinical care, which is the hard part. How do you get the men through the door? There's a lot of studies on there about educating men about prostate cancer. And, you know, just like anybody else, you're like, hey, that's great, I'll do that, but you never get around to it. Right.
Right.
So how do you, but like CHWs that are part of the community that are around can be like, all right, I'll meet you there. Let's go there. Let's go to this and let's follow up. And then if there is a diagnosis, they can then follow up on treatment, navigating the system. It's a low cost intervention. It's a community-based intervention that gets to the health of the community. And it might help a place like McCormick more so than a urologist would. You know, it's like, let's get the screening, let's get the treatment, let's get the follow-up care. And I'm glad that you all are here to represent that because it's a continuum of care that we need for this, not just screening and surgeries and those things which are vital, but it's just a small part of it.
Thank you. Are any other questions for Mr. Anderson? Dr. Ford.
This is wonderful. Thank you so much for this great information and for the work that you're doing. Just a question about age. So at the games, I love what you said about going where the children are. That's where the men will be, the fathers. Do you happen to know, are these young fathers or are there men 40 and over at these games? Or what would you say is the average age?
It depends on which games you're going to. I happen to go to that particular game I went to. The kids that were there, and I'm gonna get to your answer. They were there like the 8 to 10 range, which mean they were younger parents. You know, when I say younger, but you have uncles and aunts. It will surprise you the support that they bring toward the kids. So, if you can establish that relationship or that trust, you know. Like I said, and as you were saying earlier, no matter where it is, you can find them. It's still about establishing that trust, that basis of trust. I'm not here to do you any harm. I'm here to support you. You know, like my grandma say, sometimes you go through the back door to get in the house. But you get in the house, though. That's right.
Thank you.
Yes, ma'am.
Let me ask you, the information you shared with us today, one of the things that you shared was that why do men avoid care? And you said that the information that y'all have gathered from around the state and the areas that you serve, fear, cost, social expectation, not knowing where to go, all of those are factors that play into why men avoid medical care I wrote down all that, but do you have your comments in some format where you could provide them to Mr. Hogan?
Sure.
Okay.
Yes.
Yeah, that'd be helpful.
Yes, I can also give you that study.
Okay, that'd be great. Thank you
Yes.
so much. All right, thank you, sir.
You're quite welcome. Thank you all for your time.
All right, who else?
Good afternoon. May you hear me? All right, good afternoon. Thank you for your time, attention, support, and all you do for our communities. My name is Michael Young. I'm a certified community health worker, the executive director of Good Samaritan Clinic, a board member of the South Carolina Free Clinics Association, and the president of the Men's National Community Health Worker Alliance. And I'm a resident of Senate District 19. And I've been a part of the CHW growing movement alongside these powerhouses like Terry Jowers and Julie Smithwick and Maria Martin and Lily Fox. So knowing I'm a man in this space, I know the importance of that looking like the community we're trying to reach. I'm proud to call South Carolina home, and today I'm here to speak for the men who build this state, the men who work our fields, our factories, our construction sites, and too often suffer in silence. Men in South Carolina are dying, on average, 6 years sooner than women. That gap isn't just about biology, it's about access, trust, and connection. We delay care, we push through pain, and when we finally show up to the doctor's office, it's often too late. What could have been caught early becomes costly, complicated, and sometimes fatal. At Good Samaritan Clinic, 40% of our patients are men. Most of them hardworking guys from agriculture, construction, and labor industries. And that's probably because our hours as a clinic are in the evening, right? So we open up to address those hours. And we have one community health worker on staff, and she's a female. But I mean, this word of mouth movement, the support of each other is evident in our efforts. And imagine if we had more men to, get that word out. They're not avoiding care because they don't care. They're avoiding it because they can't afford to take time off work, or they don't feel understood when they do. One man told me, "I don't go until I can't stand it anymore." Another man said, "If my friend goes first and says it helps, then I'll go." That's why the messenger matters. When a man hears truth from another man who's been there, who speaks his language, who meets him where he is, that's when change starts to happen. That's what community health workers do. We don't wait in clinics. We go to barbershops, job sites, churches, and basketball courts. We build trust first. We talk about what's hard: prostate cancer, diabetes, depression, even suicide. We call it courageous vulnerability. Because when one man finds the courage to talk, another finds the courage to live. Now, I know prostate cancer is the focus today, and it's critical. But when you invest in trust and connection, you don't just prevent cancer, you prevent heart disease, kidney failure, addiction, and loss. You strengthen families, you save lives, and you save money. We've talked about for every $1 invested in community health workers, research shows nearly $5 in return through fewer ER visits, better outcomes, and stronger communities. So yes, prostate cancer awareness starts the conversation. And I'd like to say that what we're doing here in South Carolina really is impactful because as the Men's National Community Health Worker Alliance, we are kind of the epicenter, and these men are part of my group. We're bringing in, in July, we had a speaker from NYU that was a prostate cancer expert. So what we're bringing together and shining is informing and educating policies and other community health workers nationally. So we are kind of a shining light here, which is kind of spectacular. So yes, prostate cancer awareness starts the conversation. And Men Reaching Men turns that conversation into action. Action that saves lives, protects families, and keeps South Carolina's men healthy, working, and leading. and some other initiatives that we're a part of as a CHW from MNCHWA and part of the Center for Community Health Alignment. I'm an ambassador, so we've developed specialty training curriculums around cancer. We've been working with the SC Cancer Alliance with Nicole Eccles, who you said I think was here yesterday, to develop a curriculum specific towards addressing the disparities, the frequencies, but particularly men versus women in these cancer rates across this state. All right. Action that saves lives. Action that saves lives, protects families, and keeps South Carolina's men healthy, working, and leading. Thank you for believing that connection is prevention, and that when men help men, we change the story for all of us.
Thank you, Mr. Young.
Thank you.
Any questions for Mr. Young? All right. Thank you very much. Thank you.
Good afternoon, everybody.
Hello.
My name is Daryl Ray. I'm a certified community health worker. I work with D. Ray Group Consulting Specialists. I'm also part of the South Carolina Community Health Workers Association, as well as I sit on the board as the Men's National Community Health Worker Alliance. And that's a mouthful, so forgive me. But there are a few things more uncomfortable than talking with your doctor about your prostate, unless your doctor doesn't give you the details about the exam and does it anyway. I'm gonna give you my experience, and if you laugh, it's okay. But this was my experience. Okay, I went to my doctor. She kept telling me, "You got to get your prostate exam." Experience. What would have helped is, if we had trained, trusted men just to give me a conversation, Daryl, hey, when you go there, this is what's going to happen, And if I had someone that was trusted to tell me this information, hey, I would go, And then we're comfortable having tough conversations about screening, results, and treatment options. And then one thing about CHWs, we don't play doctor. As a CHW, we go and talk to the people that's seeing doctors on the processes they need to go through. We help them ask what's important to you, and then what you do, you need to ask your doctor. So we're training the patient how to communicate with their doctor more effectively, because a lot of times that's not happening because they don't know what to ask, or what to expect. So when men reach men, we get earlier screenings, better communication, and better outcomes. Trained male community health workers don't replace doctors, they rebuild trust. And I think one of the things you guys said in here today that really spoke out to me is it's a whole ecosystem that has to work together. And having men reaching men is going to help you do that a lot more effectively. And in my closing, prostate cancer awareness may start the conversation, but men reaching men turns that conversation into action. When we invest in prevention and trust, we don't improve men's health, we strengthen South Carolina as a whole.
Mr. Ray, thank you very much. I want to ask you, you sit on the national board for the Men's Healthcare Workers Alliance?
No, the Men's National Community Health Workers Alliance. That's the one Mr. Mike just got telling you about.
That's a national association?
Yes,
And you're on the board of that?
yes.
So do you know if is that group aware of any type of prostate cancer awareness initiative that is being done in another state that we should consider doing in South Carolina that we're not already doing?
At the moment, we're not aware because we're still new and getting up to speed, but that is something we can definitely research.
Well, if you find out anything, please let Mr. Hogan know.
Definitely will.
We need to know before, really ideally before the beginning of, before Thanksgiving.
Okay, we can make that happen.
Other questions? Dr. Ford?
Yes, I just wanted to say, first of all, I'm so sorry that you had that experience. And you're absolutely right. The process should have been explained to you from start to finish.
Mm-hmm.
But the good news is that exam is no longer routinely done. So to check for prostate cancer now, they're not really doing that exam anymore. Now it's just a...
Yeah, I found that out later, and I'm like, what? I'd rather get poked with a needle than poke with that finger, you know. So,
Yes, sir.
so yeah, but that is good, and that's one thing that we were actually at a fair in Sumter, and they had it going on, and we actually, me and Mr. Vernon, went to all the men that were there and spoke to them and got them to go get that done because they were just walking around it because, like, the thing is, you have access. But to get them into the table, most men aren't going to do that because we're real private about our health. You could have a big van up in there and say, get this test done, but if it's in a public place, I'm not going to go do that because I don't want to see people see me going in there. You know, so it's a privacy thing. Some of it's our ego, and it's just how men are built. We're built a little different because we always, like he said, want to appear strong. And so just, you know, men reaching men, we know how to communicate with one another. We just have a certain way we do things, and I think that is going to be the thing that's going to make a difference for everybody, and especially improving outcomes in South Carolina, especially on getting your data correct, because you're getting data, but you're not getting all the data, because there's that underserved communities that you're not getting data from, and so. Like you said, available data, yeah, it shows one thing, but if we can get the men reaching men out there into your communities and get more men getting screenings and stuff, now we can start getting accurate data and then really tackle this as a whole.
Thank you very much.
Okay, thank you.
Hi, y'all. I'm Terry Jowers. I'm the Executive Director of the South Carolina Community Health Worker Association, and I'm a certified community health worker. I'm a resident of Senate District 40. However, from 1976 until 1985, Barnwell County was in Senate District 8, represented by South Carolina's great statesman, Senator Nikki Setzler. And I want to thank Ms. Bledsoe, who gave some great shout out to community health workers. Regional has a great team of community health workers. Unfortunately, only one of them is a male. So I'm here to talk about dollars and cents, and I was going to do a PowerPoint presentation, but it's getting a little late. I'll send it to you so you'll be able to see this. But I wanted to talk just about the cost of screening and the cost of treatment and what we could do around this. So we know that the numbers of men who've been screened are dropping dramatically. So from 2017 to 2024, they've dropped from over 40% to 32.8. And I understand how targeting screening makes a lot of sense. So if we target and we increase, and initially, we may see some cost increase in that particular area. But when we look at diagnosis and the cost of treatment, so if we catch folks early, that treatment costs about $150,000. If we catch them later, it costs closer to $300,000 on average. So if we just multiply out catching half the folks that we have now, if we catch them earlier, we could save almost $500 million in health care savings. I live in Barnwell County, where in 2014, with 36 hours notice, our hospital closed. And when you look at the number of folks who are newly diagnosed cases of prostate cancer, we're way down there. But when you look at the number of folks or counties where folks actually die from prostate cancer, we're near the top. And a lot of that is about reaching people earlier. Community health workers are a great return on investment. We know for every $5 spent, every $1 spent, there's almost a $5 return on investment. In 2024, Medicare began paying for community health worker services. And we're excited about this, but there's a slow uptake. So we're working with physicians. We met with Hollings Group last Friday to talk about the way to increase community health worker involvement that could be paid by Medicare, and which would ultimately save dollars. In South Carolina, Medicaid and private insurers do not cover community health workers extensively. Most manage or have community health workers on their staff, but it's a small number. And currently, community health workers are funded by ever-decreasing competitive grants. So our workforce now is around 800 certified community health workers. Unfortunately, less than 200 of those are males. We understand that a 3 to 5 year investment in men reaching men could develop a strong workforce of male community health workers across the state who could be embedded in community-based organizations, rural and community health, and provider networks. These trusted men are from the communities they serve, are trained to meet men where they are, to have those difficult conversations with courageous vulnerability and move them to take action to control their lives. If South Carolina is serious about improving health, increasing the workforce, and reducing health care spending, the South Carolina Community Health Worker Association and community health workers across the state are ready to partner with you.
Thank you. I have a question. You said that if you catch the disease early, then there's a certain cost, and if you catch it later, there's a certain cost. When you said catch it early, which
In stage, I'm just saying.
What stage are you?
So with some of the, when I was doing the research, some of the early, what I read was that the early treatment costs less than later. And if you can think about that, and that was for the first year of treatment and how it can be more involved the later, or the later stage, different stages that prostate cancer is called, as with all cancers.
You live in Barnwell County.
Williston.
Yes, ma'am. Very familiar with Williston. And my Senate district used to go all the way to the outskirts of Williston until the last census redistricting, and it contracted back to
White Pond?
Yes, ma'am. So in your area of Barnwell County, how many community health care workers are there in your general region of
Right, so there are none that are employed by any providers in Barnwell County other than the health department. And we have some coverage for maternal child health through Family Solutions of the Low Country. So when you think about community-based organizations who are the boots on the ground, the closest you can get, they are competing against each other for these grants to hire and deploy community health workers. And there are many rural areas like ours that just aren't covered now. And that's why we feel like an investment in our workforce would have a huge return on investment.
Other questions? Anyone? Oh, Dr. Ford.
Thank you for your statement about the need to invest in the workforce development of community health workers. Can you describe the training of community health workers, what the program looks like, how many years, and how much it costs to educate one, to certify one community health worker?
Thank you, Dr. Ford. So in South Carolina, the Community Health Worker Association met for the first time on December 19th, 2014. And we had already had established a credentialing process at that time, but it has evolved to be one of the best in the nation, and we are constantly held up as an example. So the association has a credentialing council made up of community health workers and key stakeholders who set very high standards for community health workers. There are national core competencies that we meet. There is 80 hours of classroom, 80 hours of practicum, a state exam. We have 3 organizations that are certified to teach community health workers in South Carolina. The Center for Community Health Alignment, PASOS, and South Carolina State University. The average cost is about $2,000 per community health worker. We also have recertification, so continuing education. We have tiered certification, so community health workers can grow in our profession. And we have specialty track trainings, which is a minimum of 16 hours or more in a concentrated field. And as we mentioned, we have one that's on cancer. The one that we really want to build is much larger, about 30 hours, and it really focuses on men, reaching men. And we feel like with this team of great guys behind me can help us develop a training that could really build up a workforce of male community health workers. Thank you for asking.
All right, any other questions? Thank you very much. Thank you. All right, now we're at the point of the agenda where if we have anyone who is here present that would like to address the committee, please let me know. Anyone? Okay. All right, so now we're at the point of the agenda where we have a general discussion on the path forward. I want to recognize Mr. Gene Hogan and ask him to update us on a couple of recent developments on some stuff that we're considering in an effort to increase awareness in South Carolina.
Thank you, Mr. Chairman. And if I may, let me follow up on a couple of items that we were waiting to hear on from the last meeting. We heard from the Department of Commerce. They surveyed, at the request of this committee, they surveyed their 30 largest affiliate companies, and unfortunately none of them have any action in terms of screening nor of educational efforts. We are waiting to hear back from DHHS. They have been very actively engaged in a lot of issues that have a short fuse on them, and so they need a little bit more time to get back to us, but they have assured us that they will.
Before you go on to the next couple of things, going back, so on Department of Commerce told you that they have surveyed the 30 largest companies in South Carolina and none of them provide any type of prostate cancer awareness within their employee pool?
No, sir, there was neither a screening effort nor any type of education or effort to promote a screening.
Okay, all right, thank you.
As I said, DHHS will respond to us. They just have not had the opportunity to do that as of yet. Regarding the question that Dr. Abear had about delays amongst the insurance payers, we haven't turned over any information with that yet. We've talked with both Department of Insurance and AHP, who presented last time, and we're yet to come up with any follow-up information there. Mr. Chairman, we did speak to the Department of Motor Vehicles. We were looking for the most basic societal choke point where the most people can be reached. And the thought was, what is there but a driver's license? Everyone has to have a driver's license. Everyone has to go through DMV. DMV has offered to load and of course they will send us they've sent us the specs on this, but they've offered to load either a still or a short video on all of their monitors in all of their offices that would promote prostate screening. Also, we've had some cursory discussions with DPH regarding a potential ongoing advisory body that can be proactive in getting back to the legislature. Science changes, medicine changes, technology changes. And so the thought was that there should be some body out there that's dealing with this on a regular basis and not waiting to be charged by the General Assembly. DPH may not necessarily be the path that we would go down to do that, but it seems most likely that it would be. So we're...
And for those that may be watching or present who don't know, that's the Department of Public Health.
Public Health, yes, sir.
All right. Well, I think those are some, especially those last two, are very positive developments for us. The DMV piece and having an ability to promote awareness at a South Carolina Department of Motor Vehicles branch location. Everybody in here has been in a DMV. You know that they have the monitors in there that have information that's displaying periodically every few seconds. This is an idea that we, Mr. Hogan came up with, and we've asked about it, and to their credit, the DMV is receptive, and we intend to include it as part of our recommendations in our report. And I think it will go a long way as another step in the process to promote more awareness in South Carolina about prostate cancer and the need to be screened and treatment options that are available. Any questions for Mr. Hogan? Dr. Abear?
Yeah, so it's a comment, not a question. So I was hearing from the community health workers that they were adopting a very holistic approach, which I like very much. Strongly in favor of that. And I'm a little concerned if the idea is to make the focus on prostate cancer screening outside of that kind of context. I would feel a lot more comfortable if it were in the context of making men more aware of the fact that they need to attend to their health as part of an overall program rather than focusing on prostate cancer screening per se.
Is that a question or a comment? Or
that was a comment.
Okay. Yeah. Representative Alexander?
Thank you very much. I just received a text from Nicole Echoes. She's with the South Carolina Council Alliance. She once worked for Hope Health in Florence, and we've been passing out information to the various plants about screening. And she mentioned to me that QVC, which is right down the street from me, will be willing to screen some of their employees depending on how we would manage that and work that out. So we'll be getting in touch with QVC to see what that looks like. And that's a huge operation out there, number one. Number two, when COVID came around, the local TV stations, the local radio stations allowed public service announcements about various things. Maybe we could take a look at them and have some opportunity for people in various locations to do some public service announcements. And I think if we would take the model when breast cancer was at an alarming rate, what they did, they showered the media over and over and over and over and over again. So it wasn't like it was an activity, but a process. And I would hope in our programming that we don't come up just with a hit activity, but an ongoing process, constantly. Because we're not gonna get them all at one time. One public service announcement is not going to do it. It has to be constant. Like a commercial. And maybe we could look at that in terms of our local radio, TVs and radio stations on a constant basis. Thank you. But I'll follow up too with QVC to see what they're doing and to see what they are thinking about. And maybe we can employ that statewide, I don't know, to other companies.
All right, thank you,
And
sir.
QVC does have to be in my house district too. Thank you.
Dr. Ford.
Yes, sir. This has been very helpful information, and the part of the proposal that we set forth for the state focuses on providing education to Black men about their health in the context of prostate cancer screening, but the information applies to their overall health. So we covered topics. We shared the paper that we just published, but we're proposing to expand that statewide. That was part of the proposal. But that includes information about healthy eating, physical activity, not smoking, the other risk factors. And the great thing is that they're all the same risk factors. So the same risk factors for cancer are the risk factors for diabetes, for heart disease, for other chronic conditions. And that proposal also includes patient navigators, which are a type of community health worker. So the patient navigators, after the men are educated, their role would be to navigate the men to screening, to call them weekly, talk with them, identify their barriers, develop that relationship, trusted rapport, and then guide them to cancer screening. So I just wanted to add that. Thank you.
All right, thank you, Dr. Ford.
This is Kim Hill with ACS. The Best Chance Network program has used the DMV to have the public service announcements run, so we could maybe reach out to them and see how successful that's been and if there's anything that they would do differently. I believe that it actually listed a number for women to call to schedule their breast and cervical cancer screening, so there was a number at the Department of Public Health that women could take action. I think going back to what the gentleman with the CHW Association, getting men to take action. So, as we know, adult learning, it takes hearing something, I think, 8 times before it registers. So I think it can be a multi-component campaign that, you're hearing it on the radio, you're seeing it at the DMV, you're potentially then primed for a conversation with someone face-to-face, one-on-one. So I think that's where we'll have the biggest impact.
Can you follow up with Mr. Hogan with that information?
I'd be happy to.
Thank you so much. Other comments, general discussion? So we go ahead.
And I will follow up with our organization to see what best practices there are nationwide and to find out what's going on. And I bring back to Mr. I refer that to Mr. Hogan.
All right, sounds good.
Thank you.
So we have a report that we have to finish before December, or on or before December 31st. And we're going to do that. And so I am open to having a discussion with any of the committee members or anyone else privately after this meeting or anytime in the next few weeks. I know if you've got information you want Mr. Hogan to have so that we can consider it. Dr. Abear and Dr. Gimbel have been working on specifics to be included in our report. I know Dr. Ford had some things that she thought we should include in the report. I know Dr. Bennett has a expertise with his role with rural and primary care across the state. So we are open to any suggestions, and we've had a lot of good input today. We had a lot of good input at the last meeting on September 9th and then the meetings before that. And we have the opportunity in South Carolina to lead the country in promoting prostate cancer awareness and decreasing the rates of prostate cancer deaths in the male population in our state. That is what our goal is, and that's what we intend to do. And I want to thank everybody on this committee for your efforts and the time that you have committed to this very worthwhile cause.
And one more, Scott. Scott just texted me and said that he will be in touch with the National Government Association, see what other states are doing in reference to prostate cancer. So I think by just having this here, it's going to generate a lot of interest from other entities as well. So we're going to be looking for Scott to see what other states are doing.
Good. All right. Yes, sir.
All right, Scott, put you on the spot, man.
Anything else for the committee today? If not, we want to thank again everyone who came today and appreciate your efforts in this worthwhile cause, and want to thank those who've attended and those that have watched this online. We're now adjourned.